Well, hello, everyone. It's great to be with you all. It's a pleasure to have a discussion about nasopharyngeal carcinoma, which is a disease that is not very common in the United States, yet a disease that is relatively difficult to treat. And also significant advances have happened, especially in the immunotherapy field over the last several years, mainly over the last 5 years or so. My name is Dr. Nabil Saba. I'm professor at Emory University, and my area of expertise is head and neck cancer. And I'm very glad to be joined today by a renowned expert in head and neck cancer, Dr. Jennifer Cho from Vanderbilt University. And so we're going to try to keep this as informal as possible, but we'll try to give you some information about this disease, and we're going to entertain any questions you have during this discussion. So first of all, globally, this disease affects one patient in 100,000, but there is quite a bit of geographic discrepancy. The disease, especially when it is linked to the EBV virus, is more prevalent in southeastern Asia, including China. So in some portions of China, the incidence is 25 per 100,000. Again, it's linked to the EBV virus infection. However, in the United States, we do see some other subtypes, including the HPV subtypes, which is a disease that affects mostly the oropharynx, but the predominance worldwide remains to be HPV. So maybe that's a good time, Dr. Cho, to ask, in your institution at Vanderbilt, can you assess how many or the proportion of patients you see with HPV versus EBV positive disease?
So the vast majority of our institution has probably more HPV associated. We do see like a reasonable number of EBV associated, but as it's mostly associated with Asian populations, most of ours are what we consider non-endemic form of NPC.
Yeah, no, I do agree with that fully. And we're not very different geographically, of course, Emory and Vanderbilt. And we do see quite a few patients who are not EBV related. But we do also have quite a bit of an immigrant population here. So we do see quite a bit of EBV related disease as well. So let's go to the next slide here. And, let's talk a little bit about how we evaluate these patients and how do they present. They present with the symptoms that are listed here in front of you. So they may present with headache. They may present with a lymph node in the neck or a sore throat, nasal congestion. And so that may be a good time to start discussing perhaps how do we evaluate these patients and how are they referred to our institution. Certainly at our institution, we are a referral basis for these patients. So they come to us referred from otolaryngologists in the community, sometimes internists. Is it the same situation for you, Dr. Cho, or?
Yeah, and obviously they'll obviously come through our own ENTs, otolaryngologists at our own institution. They frequently come in with having nasal obstruction, really stuffy nose, bleeding from the nose, and obviously central facial pain or headache. And so the otolaryngologist will typically refer to medical oncology, and we'll talk about consideration of preoperative therapy. So yeah.
Yeah, and I have to say, and to add to what Dr. Cho said, those are patients who need a multidisciplinary team, and this is a complex disease to treat, and we'll talk about it in the coming slides for sure, but this is just a review of the symptoms at presentation. And when we try to evaluate these patients, we do, as you can see here, several things. Of course, the clinical examination is important. Getting a tissue biopsy is important because we obviously want to confirm that this is nasopharynx carcinoma and not another histology. In this part of the head and neck area, you could have certainly other diseases. Lymphomas have been reported. Other types of tumors have been reported. But usually when you come to a referral center such as ours and Dr. Cho's, there are quite a few experts who will tell us and guide us exactly as to what they think this is, whether it is radiologists, and we certainly have experienced radiologists who can tell us if the disease is consistent with this. Nevertheless, we always need pathology. We always need a pathologic confirmation. And it is important, I think, also to check on whether this is an EBV-related cancer, Epstein-Barr virus, or a human papillomavirus-related cancer. But let's talk a little bit about the multidisciplinary team, because I think this is a very important aspect of the discussion. And Dr. Cho, why don't we start by asking, how is your multidisciplinary team at Vanderbilt structured, and how do you see these patients? Certainly at Emory, we do have a system where when the patient comes in, and I was just in the MDC before going on online, where we would see these patients as a team members in one day. So they get seen by the otolaryngologist, the medical oncologist, radiation, in addition to nutrition, therapy. It's really a multidisciplinary effort. And then the patient comes out with a unified recommendation after we discuss the case and after we have radiology review the scans with us. And so it really takes a long time. It's a long afternoon for the patient. They come in, they spend about 3 or 4 hours in our clinic, and then we basically come up with these recommendations. Is that a similar situation at Vanderbilt, or how is it? How does it go at your place?
Yeah, I mean, that's the most highly preferable way that nasopharynx cancer should be managed, just by a multidisciplinary team with some expertise amongst all the specialties in evaluating the nasopharynx cancers. Obviously some of them will come through a referral basis and may have already been diagnosed by a otolaryngologist and then got referred in. And so maybe they will then see the teams kind of separately, but ideally they should see all members of the multidisciplinary team at some point early in the treatment process.
That's very good. So I'm glad we're not very different in the two institutions. Besides the EBV test, would you care about getting, for example, a PD-L1 test on these tumors when they come in?
I suppose that could be a little bit controversial, because there's more data coming out about giving immunotherapy in the neoadjuvant during chemoradiation and adjuvant period. As it is now, that's not really standard of care. I typically do go ahead and send it off just so we can have it. But as it is right now, it's not considered standard of care. So technically you don't really need it if they come in with local regionally advanced disease at that time.
Yeah, I do agree with that as well. I think you're absolutely right in the sense that, we don't know what to do with it initially. I have to say the field is moving at such a rapid pace that, immunotherapy may become a component within the definitive management. Not as of yet. I don't want to confuse the audience here, but essentially, and plus the results of the PD-L1, as you very correctly mentioned, does not always correlate with benefit with immunotherapy, specifically in nasopharynx cancer. So that's another interesting aspect. So without further ado, let's go to a case presentation, because I think that will be really very helpful to our audience and for the discussion as well. So we have a 39-year-old Asian woman who comes in with a past medical history of hypertension and long-standing history of smoking. She presents with a large neck mass. It's been there for 2 months. And then she also has nasal congestion. That, by the way, is a typical, classic presentation of nasopharynx cancer. If you get asked on a board question, patient presents with neck mass and nasal congestion. And if you don't think of nasopharynx cancer, then you're writing the wrong answer. So this patient had epistaxis, sensation of fullness in the ears, which are all expected to be symptoms of nasopharynx cancer. And she had a nasopharyngoscopy, which is the standard. She had a biopsy, and she's diagnosed with nasopharynx cancer. This is an EBV related disease, and she has a T2 to T3 N3 disease, so locally advanced locally advanced disease. So let's ask the question here before we move on. Certainly, we discuss in our multidisciplinary team, our approach is to get usually an MRI for these patients because we believe an MRI is going to more accurately determine where the tumor is, its relation to adjacent structures. But we also would like to get a PET scan because many times the PET scan tells us more about this disease in terms of involvement in other organs. And there's quite a bit of upstaging that happens, I believe, in this day and age with the PET scan compared to what we used to have in terms of just CT scans. What is your approach at Vanderbilt?
We do a similar routine. We prefer MRIs. Much of the limitation often is just the timing of when we can get the MRIs and the imaging. And then a PET scan, we also do that as well to try to look for other disease. It can be more helpful for looking at nodal disease in the neck, since sometimes, MRI or CT can be a little bit more ambiguous. And if you see signal in the neck for cervical nodal disease, gives you a much stronger impression that likely is involved nodal disease for those patients.
Yeah. And most of these patients, and we'll talk about it in a few minutes, will be getting sequential therapy. So for the audience, it is important to get a sense of how much response you're having after the chemotherapy portion, because I think our radiation oncologists would really like to know this information. And I don't know, sometimes the direction is their radiation is targeted towards the tumor, how it looks after chemo, but there are different approaches here, I suspect. Both of us are not radiation oncologists, but I think the initial good evaluation with good scans is really pays off. And so let's continue for this. So we know this patient has stage 3 disease, but let's review a little bit with the audience how we manage, since this patient has stage 3 disease, how we manage stage 3 disease. We mentioned sequential therapy. And here, it's important to mention the history of how we got here. So, there was an old study, the intergroup trial years ago, and I think maybe 20 years ago or more, that essentially looked at sequential therapy. It started with radiation chemo, and then half of the patients got follow-up with chemotherapy added to the radiation chemo. And then this study suggested at that time that intensification with chemotherapy pays off in this disease. And we know already that this is a disease that is chemosensitive. So the question of how much chemo do we give has always been on the mind of experts, and has resulted in several attempts to try to answer these questions. And without really going through a litany of different trials in details, because we don't have time for that, suffice it to say that the trial that has really impacted the recent management of this disease in that sense is the Zhang paper, which was published in 2019. And this paper really asked the question, is it better to give chemotherapy first, followed by radiation and chemo, or is this going to result in the similar outcome to chemoradiation, which is the traditional way of treating head and neck cancer overall? We treat it usually with chemoradiation. And, not surprisingly, basically the sequential therapy, which is chemotherapy first, usually with 3 cycles of gemcitabine and platinum, cisplatin or carboplatin, but if the patient is healthy, they can certainly take cisplatin. 3 cycles followed by radiation and chemotherapy has been shown in this trial to be superior, result in better overall survival compared to concurrent therapy. Now, you could say this is mostly for EBV positive disease, but I think, it has been applicable, I think, in different settings, and certainly some people use it also for non-HPV related disease. Just out of curiosity, Jennifer, would you use it in an HPV positive patient? Because sometimes these questions come up, and I'm just wondering, what is your approach there?
You know, I don't really know what the answer is to this, to be quite honest, right? Because in the studies have always been in Asian patients with EBV-related disease, and then can you really extrapolate that to an HPV-related disease and presumably other non-HPV, non-EBV-related NPC? Can you extrapolate from those EBV-related cancers? Um, I tend to probably give gemcitabine and cisplatin prior to chemoradiation because that's kind of the best evidence we have. But you can definitely make the argument that perhaps the regimens should be more aligned with other mucosal head and neck patients. However, induction chemotherapy in those populations are a lot more controversial. And so can you really, that would be almost like two levels of extrapolations potentially. And so I think it's reasonable, like that you give induction chemotherapy with gemcitabine cisplatin to non-EBV because, like I said, that's the best data we have at the moment for nasopharyngeal cancers.
Yeah, and I tend to agree as well. And even though there is extrapolation, the big problem, what you're referring to mostly, is that we have lack of data in the HPV-related disease. Certainly, we have lots of data in HPV-related oropharynx cancer, but even in that disease, we're not sure whether the sequencing is currently the best because I mean, HPV-related oropharynx cancer has been basically discovered, I guess, over 20 years ago, maybe less. And so we're still in a conundrum in terms of how best to treat this disease, whereas nasopharynx, I think, has more impressive advances, whether on the immunotherapy level or whether on the sequential therapy level. So I think, to summarize to the audience, we both agree that sequential therapy is the way to go for this patient, meaning starting with gemcitabine cisplatin or gemcitabine carbo. She's a young lady, so there would be no reason to give carbo. We would give gemcis for 3 cycles and then follow that with radiation and chemo. But if you look at this table, this is not summarizing just stage 3 and 4, but certainly earlier stages as well. So if you notice, when you have early stage disease, single modality usually is acceptable, even though concurrent therapy is on the list. But certainly, radiation as a single modality, sometimes surgery also, even though that has fallen a little bit out of practice for these early stage disease, because again, this is a disease that's very radiation and very chemosensitive. And I think it's time to move to the next slide because we don't want to be losing track of the time here. And so essentially, that patient got treated exactly with what we were discussing. She got treated with gemcitabine cisplatin, that was followed by radiation and cisplatin, and you have the reference here, which is the paper that was published in the New England Journal of Medicine by Zhang et al. And she had improvement in her symptoms and has a demonstrated complete resolution. If I see there's the slide area that's blocking my view, but it says demonstrated complete response, hopefully, to treatment. And so this is great. This is what we want to see. And before we go to the next slide, I guess this is an EBV-related disease. So is there anything you would follow this patient with besides the scans, Dr. Cho? I mean, I think what I would do is follow her with usually MRI, and I tend to do a PET scan as well, just to be on the safe side. But I'm not saying this absolutely needs to happen. But certainly imaging every 3 months for the first couple of years probably is my way to go. Any difference there, or any refinement?
I definitely follow with the MRI of the primary site. I think whether or not I definitely do like a PET scan 3 months after definitive management. We tend to do, I guess, a little more contrasted CT scans of like the neck and chest after that, but certainly PET scan would be reasonable. It largely comes down to insurance coverage a lot of times, but I definitely think that each one has like its is useful. If we could get PET scans more frequently, that would actually be helpful. and does incur a cost, I guess, for cost benefit for the patients, but certainly either imaging modality would be appropriate, but definitely MRI to continue to follow the primary site.
Mm-hmm. And what about endoscopic evaluation? I think, as we said earlier, we're in a multidisciplinary team. In my view, these patients, when they get follow-up MRIs, many of them still have some residual tumor that may not really be PET avid, which is why I also get a PET scan, at least initially, to make sure that the uptake has diminished at least significantly. But then it would be good, I think, to try to scope these patients to try to basically make sure we're not missing anything. And most of them, again, this is a very responsive disease, so very rarely we see residual disease, especially in an EBV positive tumor. So I think most of these patients tend to usually respond extremely well to treatment. Um, um, what about EBV titers?
So EBV in the blood, I think there's some potential validation issues with whatever assay is being used, and that could be very institutional and depending on your lab and which EBV assay they use. There is strong evidence that EBV titers in the blood correlate to disease status. However, and Dr. Saba, you and I have talked about this, we probably use this more guidance rather than actually definitively changing our management. So if we see like a positive titer at the end of definitive treatment, we may say, that's a little suspicious, and we may keep a closer eye on the patient and do probably a little more stringent imaging. And then if it starts to rise and we get a little more concerned, definitely ask may ask the ENTs to do closer surveillance, direct visualization. I think it doesn't mean that we go ahead and start them on systemic therapy. We see the titer rising if we don't see actual clinical, radiographic, or visualized evidence of disease at that point. But it does strongly hint to us that something could be kind of occult and kind of lingering in terms of residual disease that we just can't see on imaging.
Yeah, very good point. Very good point. And I do agree completely. I think the question always is what to do with these tests when we get them. They certainly give you an idea of what's happening, but certainly don't give you clear answers as far as what to do. So let's continue here. So this lady, even though she had this excellent response, 3 months after completion of treatment, she did have a CT scan of the face revealing no evidence of recurrence. She has decreased EBV titers, so this is again testament to her response. However, at 9 months, she unfortunately developed lung metastatic disease, which was biopsy proven and proven to be EBV related. And so, so I guess maybe we can ask here, do you insist on getting a biopsy at that point? I think, that's always a question that comes up when we see recurrent metastatic disease. I think if the clinical picture is consistent with metastases from the primary, I don't always subject the patient to biopsies. However, unless there is a doubt in my mind that, this is something different. But it's always, I don't want to insinuate that we should not get a biopsy on these patients. I think it makes sense to always prove, if you can, that this is actually metastatic disease. And it may make sense to also get a PD-L1 test here on the tumor, even though, as we said, the data in recurrent metastatic disease does not show us that there's a clear correlation with PD-L1 expression when you give immunotherapy. And so I think we have a little more than 5 minutes left. Any comments on this slide, Jennifer, before we go on?
Yeah, I mean, I guess the comment on whether or not I get it, I think it depends. You have to kind of take the whole clinical scenario into context. Like if they have a solitary lesion, and let's say this was like a 60-year-old person with like 40-pack year history, you may have a question of whether or not it could be lung cancer as well. So I think it really depends on their clinical history of, or, if it's a solitary lesion or if it's like many lesions that look like, that looks like metastatic disease as opposed to a solitary lesion, that may change whether or not we really, I would go after a biopsy. Certainly in someone who's 39 years old, who probably probably doesn't have a long history of smoking. And, it's not like 40-pack years, most likely. And they present with like lots of, lung nodules. I probably am not going to necessarily biopsy that, given how close, especially it was to the prior treatment.
Okay, since we just have 5 minutes, I'm going to just try to move rather quickly over the next few slides. And as you notice here, we have put a QR code down in the bottom of the slide, so you can basically claim CME credit. So just to summarize, for immunotherapy, as you know, when a tumor expresses PD-L1, it is trying to essentially hide from the immune system. That's what the PD-L1 is allowing these tumor cells to do. And as you know, this is why what we've been discussing, does it make sense to get a PD-L1 test? But when you give a PD-1 inhibitor, and there are multiple PD-1 inhibitors, you reverse that process, and then you allow the lymphocyte to essentially attack this cancer cell. And I'm sorry, the slide is rather small, but this is a list of PD-1 inhibitors in nasopharynx cancer trials. You can see that the responses of the newer generation PD-1 inhibitors, such as toripalimab and others, tislelizumab, and others, essentially is rather more generous than what we're used to. We're used to a response rate of about 20% in non-nasopharynx tumors. Certainly, if you look at older studies with the traditional PD-1 inhibitors with nivolumab, pembrolizumab, you get a response of what is expected to be as 20%. Of course, these trials differ whether you give chemotherapy with the immunotherapy or not. And just to remind people that the Jupiter-2 trial resulted in positive results, and recently in late 2023, almost a year ago, the FDA approved the combination of toripalimab with gemcitabine and platinum for first-line recurrent metastatic patients. So certainly this would apply to this patient when we decide on what to give in terms of systemic therapy. As a reminder, toripalimab is a PD-1 inhibitor, and the Jupiter trial was PD-1 inhibitor with tori plus chemo, gem platinum versus chemo, gem and platinum therapy. And sure enough, this patient got treated based on the Jupiter trial with gemcitabine, platinum, and toripalimab. She had a complete remission to therapy and improvement in symptoms, which is great news. And we can talk extensively about how to follow this patient from here on, but I don't think we have time because we're running out of time. We still have 2 minutes, a little more than 2 minutes. And so just in the last portion of the discussion, I think it's important to mention that these agents, even though improved outcome for patients with recurrent metastatic head and neck cancer in general, but also now with a toripalimab Jupiter trial, have improved the outcome for nasopharynx cancer more specifically. I think it's important to recognize the possible side effects related to these agents, and those are listed here. And they apply to all immunotherapeutic agents, not just to toripalimab. I guess one question before we close. Before toripalimab was approved, we saw that people were using pembrolizumab, and certainly I have used pembrolizumab based on the data that was shown in these 3 phase 3 trials. But I think since toripalimab has been approved, I think we've all reversed to toripalimab because we believe that this is the level 1 evidence, and we don't have other clear evidence as the Jupiter-2 trial at the moment. Is that your impression too, Jennifer?
Yeah, I mean, we by and large consider PD-1 inhibitors kind of somewhat equivalent. However, Pembro did have a study where they did not combine it with gemcitabine cisplatin, which may have been the reason it didn't meet its primary endpoint. But because toripalimab has the positive data in combination with gemcitabine cisplatin, I do tend to favor toripalimab.
Yeah, and we have a little more than half a minute left. I think we talked a little bit about the multidisciplinary team, the logistics of management. Certainly barriers exist to these patients, and so we want to try to remove these barriers as much as possible. And we're sorry we're running out of time, so we cannot really elaborate too much on this. But I want to say this has been a great discussion. And I'm really glad to have this discussion with you, Dr. Cho, and hope to see you in other similar events.
It's been a great talk. Thank you, Dr. Saba.
Thank you so much. Bye-bye.